Matt Gilman, Harvard Medical School. Thanks for those great talks. I guess this is mostly for Karen and Mark, and it's about this, the fact that we often see similar phenotypes with sort of adverse cues at both sort of the upper end of prenatal nutrition and the lower end. And you made one hypothesis about that, Mark, and I'd like to hear your and Karen's view about why you think that is. What do you think the differences and similarities are, and what does that mean?
Yeah. That was it. Well, good now? Cheers. Sorry about that. In our case, many people associate maternal obesity with macrosomia and fetal overgrowth. But in our models, maternal obesity is commonly associated with fetal growth restriction. And we've associated that and published on that in terms of placental insufficiency and changes in placental structure and function. So I think that may be a similar pathway by which undernutrition and our models of overnutrition result in a similar phenotypic outcome. Because we know offspring at both ends of the spectrum tend to be hypoleptinemic and hyperinsulinemic and reduced birth weight and length. So there's a commonality there. Most rat models of maternal obesity don't lead to overgrowth or macrosomia at all. There are some mouse models, but I think that's where the similarities lie.
I was also going to say that I think Mark's done some very nice work on how puberty is accelerated in both undernutrition and also overnutrition. And although you get to the same point, they're reached by very different sort of mechanisms. But I mean, I think in the human setting, it will now be really interesting to sort of compare the pathways of both under and over nutrition and to look at the epigenetic changes or signatures associated with each pathway. And of course, there is this question of whether overnutrition is some or is a consequence of malnutrition in terms of micronutrients, etc. So, I mean, they might not be so disparate at the end of the day.
Am I allowed to ask one more? This is just a question of Kevin. You asked people to raise their hands if they thought that high-fat diet followed by high-fat diet would be good for you. But if we believe the mismatch hypothesis, that's a perfect match. So can you comment on that dissonance?
I think it depends on what the severity. So if you get really sufficient or really significant placental insufficiency in your model, and you do get an SGA outcome, then maybe long-term fat may be the answer. Now, the metabolic stuff that we're seeing almost suggests that the high-fat diet offspring may deal with fat better than control outcomes. The problem are the other complications that eventually gear up. So the inflammation components and especially the brain components, that ends up in the long term causing more and more damage, I think. So
yeah, a lot of people argue that the mismatch only works for one side of the equation, undernutrition. But nobody's done enough work to see if a high fat matched to a high fat, there could be healthy obese. You don't know.
I mean, what we've done is we've bred mice over 4 generations on a high-fat diet, and what you do see is some adjustment in terms of metabolism, but that adjustment only appears to apply in sort of early adulthood, and as soon as they start to age, then you start to see all the dysfunction appear.
So my question has to do with placenta. Obviously, it's very important in between these two beings. And I seem to remember that the shape and length and width of the placenta are actually really important. And I wondered if it could be used as an indicator that this is a pregnancy or a situation suggesting treatment might be useful. So my question really for all of you is, do you think the placenta shape and size, which could be measured in humans in utero by ultrasound, would be a useful indicator of the need for therapy?
I can sort of comment. I've had several conversations with David Barker when he was alive about that. I mean, you have to understand that the shape and size is really a sign of dysfunction in his hand. So they measured it in an ovality, I think is the term that he often used for it. The difficulty is that we don't really know that all of those measurements are made, I almost said post-mortem, but postpartum. And so they, we don't know always what that shape and size looks like in the pregnancy. And so I think that is a possibility, but we need to be able to know what that looks like. And what you'd hope for is a biomarker that might be a better indicator rather than the shape and size, because the shape and size is likely to be highly variable amongst women and how many pregnancies that they've had. Yeah.
This is, I guess, a general question. I'm going to put on my my clinical hat for a minute here because I work with all these OBs, and they like working with us, but they tell us that this wave of obesity, we are really just afraid we don't know what to do, and whatever we do, we have to show that it has some longer-term outcomes. So bringing back to any intervention that we do, when you look at a rodent in particular, if you wink at it, it'll get programmed. I find that with the primates, it's a little bit more difficult. But one of the studies that Kevin had in his slide kit but didn't have time to show was this Resveratrol study, which was, it's a natural supplement, and we gave it to these high-fat fed offspring. And what we found was it did reduce the triglycerides and improve placental function, but there was a very odd alpha to beta cell ratio in the developing islet. And I think what's necessary when you do these interventions, the next step is to do it in a higher organism, for one, and then look a whole lot closer. Although you can't do multi-generational studies, you really have to have an eye for what things could be different in the human. So that's just my editorial. To move a little bit closer to human, we did a study. We were actually the first randomized control diet-treated study, which was published in Diabetes Care last year, where we took women who are the high-risk women, that is diagnosed as gestational diabetes, and at the time of diagnosis, they were randomized to the, quote, conventional diet, which, believe it or not, is low carbohydrate, high fat, isocaloric. We took that idea and said, let's make it complex carb, low fat. And when we did the analysis over time, and patients were given every single calorie. There was no tell us what you eat. We gave them the calories. The women had a better HOMA-IR score. Inflammation in the fat cell on biopsy was suppressed, and the infants were less fat. And that's now a huge R01 that's ongoing now, just to kind of take this idea that, there is an intervention. It's called diet, and women just need to know what to eat. And I think we're closer than maybe what we think. But just to caution everybody that if you're trying to get into the real world, this is where you have to start.
Yeah, I have a very quick comment, and I'll let the other ones. Hope is actually what they need. The obese women they feel helpless, they feel anxious, they feel depressed, that their children are going to experience the same issues they have. And part of it is giving them the hope that there is something that can be done, and diet is something you can change rather quickly, and they are motivated. And I think that has to be the place we start.
But doing the order of experiments is quite an interesting issue, because in New Zealand at the moment they're undertaking a small clinical trial of Viagra to women who are at risk of small babies, very small birth weight babies. But the animal data all points towards long-term negative consequences. So interested to see how that pans out.
But just like other have mentioned, there's also the question of not just what to do as intervention, but when to do it, and especially on the glucose side, we're screening for gestational diabetes or gestational hyperglycemia in most of the time, like in the middle of the pregnancy or even after. And we know that the early phases of fetal development are especially sensitive for the fetal programming epigenetic, and so maybe we need to screen and treat earlier those conditions.
I think there's been a couple of intervention trials, certainly in the UK, where we've targeted obese mums, sort of midway through pregnancy in terms of dietary and exercise interventions. And that's had some success, but then there is this question of that perhaps most of the effects, or perhaps the most plastic period, is very early on in development. So then, do we need to get the mums, sort of 6 weeks, 7 weeks? But of course, then there's the problem that the high risk groups obviously are the ones that don't know they're pregnant yet, et cetera, et cetera. So it's really hard.
And also, most of the outcomes that we're measuring right now for dietary intervention during pregnancy are short-term outcomes on the maternal or just at birth. And so I think we need to think further. If we're thinking about programming for a lifetime, the dietary or other intervention that we do, we need to either have really good biomarkers of what is the programming path that we're setting, or have longer follow-up after birth.
Yeah, maybe I'll ask Marcus, maybe he should know that metformin trial, those kids that moms were given metformin are now like 7, 8 years old, and Janet Rowan's data shows that it's an insulin sensitizer that does cross the placenta, and the outcomes on the babies. Maybe you want to comment.
I don't know much about the study. I've heard the outcomes aren't optimal. That's all I've heard, the long-term effects. People don't see past sort of survival and the immediate effect, but there is this trade-off in later life. That's a good example with the Viagra study we're undertaking. We know it allows the fetus to be born and viable at that point, but we know by maturity it's going to be hypertensive, obese, insulin resistant. So it's a short-term trade-off in order to survive, but the long-term trade-offs are pretty bad. And the metformin studies sound very similar to that. And there have also been some vitamin supplement studies in the UK. I think Lucilla Poston did one, where they ended up with an increased incidence of low birth weight babies. So it went against what they expected the outcome to be. And obviously they're at risk now for later programming effects as well. So it doesn't always pan out, and animal models don't always translate well across.
So, Kevin, your work is quite fascinating. You made many interesting comments. One particularly struck a chord. That is, you were talking about non-responders. So you had some which you basically just left it at that. So have you thought about resilience?
You reframe that to...
Sure. So right now there's the term resilience, which is coming about, which is really to look at individuals which are resistant to an effect. And so what you've got is you've got a perfect group of responders and a perfect group of non-responders, even though you're feeding them, having, under the same protocol. And has anybody started to actually consider why those people in the high treatment groups are not, basically responding in the same manner, or animals?
Yeah, and it's interesting because when we actually look in the molecular level, we don't see as many differences. So we see a lot of consistency in brain development abnormalities. The manifestation of that phenotype seems to be quite variable, meaning that you can have an animal with abnormalities in serotonin that have completely normal behavior responses. And maybe some of that is learned. And that's why I think some of the intervention studies may, I'm a metabolic person, and I believe the metabolic phenotypes that we see are the least of our worries. Because when you start messing with social cues and cognition, you've got lifelong problems in your whole community. So, but it does suggest to me, and in monkeys you got this really extensive hierarchy, and we haven't really seen the hierarchy play out of it, but maternal behavior towards the babies does seem to play a role. And so you can get some correction of the molecular abnormalities depending on enrichment of their environment, maybe, is one way to say. But it needs to be tested out in a much more extensive manner.
Thank you all very much. So, take a short break and try to be back by about 3.